Okay.
So
I see that Dave Carson is joining us, which is jolly good.
yep. Great. So I'll just give a second for Dave to get connected.
Yeah.
And then I don't see anybody else in process, so I'll go ahead and get started. Can you guys see my slides?
Yep.
Okay.
Yes.
Are you seeing this, the presenter view or the is that better?
Yep.
Okay, there we go. Okay, so as I mentioned today, we're just going to be going through the last section of the eCare plan. I think everybody on this call is familiar with the folks involved in this project, so I'm not going to spend too much time on these first couple of slides. And as we just discussed, as a reminder, so today we'll be doing the interventions review, and then next time that we sort of host the meeting, we'll do the sort of guest speaker session, and we've just confirmed Joel Andrus will be speaking from CMS and just giving a little bit of context around the interoperability rules and interpretation by CMS. So hopefully that will be of use to the group. So in terms of today, I hope to spend the first 20 minutes or so just quickly running through the intervention section and the data elements that we've included, and then hopefully get your feedback as well as point to ways to provide additional feedback moving forward. So again, that's our objective today, is to just get your input on this. I just want to briefly acknowledge where we are with the intervention section. So we have identified a little over 300 intervention data elements, and we are still in process of doing the value set identification and development. And we're aiming for completion of that process by the end of September. And so we will share that with this group, perhaps not in presentation format, but we will make you aware when the spreadsheet is available for those who may want to take a closer look. So in terms of our intervention section, we did align with Gravity on their proposed 8 intervention types, mostly with one minor exception, and that is that we added a sort of a self-management activities section. I think many on our TEP felt that, in addition to the 8 intervention types laid out by Gravity, sort of the one thing that wasn't really well covered was the things that the patient is doing on their own at home outside of the medical system that would be important to track in the context of a care plan. So in addition to the 8 intervention types, we also included intervention attributes, as we have with other section, and these are sort of the metadata, if you will, for each intervention, each specific intervention element. So about each intervention, we want to know the start date, the indication or purpose for that intervention, the dose, as in the sort of amount of active ingredient or time, depending on the type of intervention, the frequency, how often it's given, timing, is it giving morning, evening, or some other schedule, the location, including the address of where the intervention will be provided, the actual provider or person who's responsible for administering the intervention, the stop date, if applicable, the reason stopped, if applicable, any past interventions for the same indication, past intervention failures and reason for failure, side effects from an intervention, the reason an intervention may differ from guideline-based care, intervention endorsers, so care team members who maybe aren't the responsible party for the intervention, but who endorse the intervention, the status of the intervention, so is it planned, completed, or ongoing, primary funding source to pay for the intervention, the out-of-pocket cost to the patient, the intervention unit cost and total cost, and then financial assistance need in order to complete the intervention. I guess I'll keep going, and then maybe we can flip back through the through the slides if people have specific comments. But if somebody has a burning comment, this doesn't have to be super formal, so please feel free to jump in if you see something that catches your eye or you have a question about as I go through these. So moving into our intervention types, we have referrals was the first type in the gravity paradigm. We added sort of one specific attribute to referrals, which was sort of the closed loop referral. What is the status of the referral in terms of whether the person actually received the service? We know there's a lot of work going on in thinking about how to do that, but we did want to acknowledge that we sort of endorse and agree with the need to close that loop on referrals. And then we have a variety of referrals for numerous different contexts, particularly aligning to our primary use case conditions. I'm not going to read through each of those, but just want to acknowledge that they're here. And again, if folks see something that catches their eye, please feel free to speak up, or if you see something that you feel like is missing, we'd also like to hear that as well.
Hey, Jenna, this is Becky Gradle with the Academy of
Hi,
Nutrition
Becky.
and Dietetics. I have a question on the closed loop referral. How is that differing from a referral to someone else? So for example, if a person is referred to a dietitian, when the dietitian sees them, they'd write the note and they would refer that back. And I realize that's probably not necessarily closed loop, but if you're using this as a value set aspect, that closed loop referral may get you into some trouble that if nothing else applies and that one does, then you can't use it as an extensional value set, I believe.
So I think where closed loop, so just contextually where closed loop referral I think becomes really important is more for community-based referrals. So often in the social determinants of health space, when you refer out to, housing assistance, so some of these food assistance, housing assistance, you never know what happens. So you never know if the patient or the person received that service or even showed up or what happened. And that's, I think, in part because of the disconnection of the community-based providers from sort of the health IT infrastructure. And so that's something I think that's being worked on, I know in the gravity context as well, or being thought about to some degree. In terms of, so I'll admit we have not figured out exactly what the value set might be for closed loop referral. And as you sort of suggested, it might be very specific to a particular referral, right? So like you could look and see if a nutrition service were completed to see if the referral had occurred, if I understood your comment correctly. Yes. Anyway. Yep. And so, perhaps not positioning as an attribute. But I think, yeah, I mean, I think it's a good question. I don't know that that's the end all be all approach. I think in some ways this is here as sort of a placeholder to acknowledge that it's an area that needs more thought and more thinking, and it may be something we ultimately put on hold, which has happened to some of our data elements as we've gone to try to support them with standards, and it turns out that there just really isn't a good way of doing that as of yet, and it's something that we'll have to sort of circle back to in the future. So that doesn't really answer your question, other than
this is Emma. There is a closed for closed loop referral is not necessary. It's not necessarily just for community based. It's also for clinical care as well, because I know there is like IHE has a closed loop referral profile in which you make the person requesting the referral want to know if the appointment was made, if the patient actually went to see the consultant, and also what was the follow-up results from that, so that they can know so they can know how to plan the next step in the care process. So that it is a real use case, and I'm not saying that you guys don't think it is, but anyway, it's not just community-based, it's also, for clinical care as well, just to make sure things doesn't fall into the crack. And there is an IHE profile that deals with that. It's called the 360X.
Yes, and I didn't mean to imply that it wasn't an issue in the clinical context. Yeah. I guess what I was saying is that I think the approach that Becky was suggesting, if I understood her correctly, was that you could sort of infer based on the later services that were provided, whether whether the referral had occurred, but I think that's not always the case.
Yeah,
You know,
exactly.
particularly.
So,
Yeah.
Yeah.
And I was trying to say
Bob.
that we're inferring that, but I was just saying that it is a problem, trying to figure out if this really happened or not. And it's a problem that we need to solve.
Yeah.
So this is Bob. In the work that we did for the Gravity S2H implementation guide, we have defined a closed loop referral process that actually provides information on the status of a referral to a community-based organization or to another provider, and documents what was actually done as part of the response in closing a loop. The thing we're working on right now for the next version of the implementation guide is how to do the same thing with the patient. In other words, how do we get them to document from their point of view what happened, so we can close the loop both directions, to the service provider, but also to the individual receiving the service.
Thanks, Bob. That's really helpful.
So a couple of things regarding closed loop referral. So do you have then attributes within your intervention cluster which will allow for, say, for example, a service requester to indicate that they want some feedback sort of to be given from the referred to organizations or provider?
Yeah, so I mean, I think it would be, oh, sorry, was that a question for Bob? Go ahead, Bob.
No, I don't know. Were you asking me, or were you asking?
No, I mean, I'm just asking a general question where either Jenna or you sort of might have an encounter, and I'm happy to hear from both or either one of you.
So the way we had designed the closed loop referral process for social determinants of health was, this is a FHIR-based solution. So you're posting a task, you're getting a copy of a service request, which defines what you want done. The task goes and manages a status, and we have a way through subscription to go and make sure that both the ordering provider or the referral creator and the referral recipient have a way to go and manage the current status. Part of the requirement that we have is when it's done, when you mark it as completed, you attach to the task procedures that document what was done. So we have a record of what was completed. So if I refer somebody because of food insecurity, I might have back a procedure that indicates they were evaluated for a SNAP program. They've been enrolled in a SNAP program. They also wind up are getting food from a food pantry. So we actually have the way to go and say, not only did you ask me to do this and I did it, but here's exactly what I did. And we're planning on doing a similar thing, but not identical, with the individual. And that is to have the individual describe, well, for example, I didn't go. I did go and I got a service. I had a problem with scheduling. We have the ability to go and attach a questionnaire, for example, that could be very specific to the type of service, or could be very general to the, do you speak the same language? Was it scheduled appropriately for you? Is transportation a problem? You know, basic interaction issues related to that particular service provider or that service. So we're trying to understand how far we need to go, and I'll say standardizing an exact set of questions regarding services in general versus allowing the flexibility for a service to define a specific set of questions, meaning a questionnaire, for example, that could be administered through the individual smartphone application or whatever, to go and determine for that service, did it work? Does that make sense?
Yes, so therefore you would then depend on the behavioral aspects of the application or the system to perform that sort of say if you have a questionnaire out there that we expect someone to complete, whether it is the patient or the community services, So do you then rely on the application or system behavior to send those people reminders? So therefore they can then complete those questionnaires or a services report and then send it back to the referrer?
Exactly. Well, given that we're doing this as part of task-based exchanges, we know whether the task has been completed or not, so you could always follow up on the task to ensure that it actually did complete it. But we're looking at two very different things. From the service provider, it's what did I do? What do they claim they did? From the individual, it's what did I receive and how did that work for me? So it's a slightly different flex on it. And in the case of the service provider, it's procedures coming back with appropriate SNOMED, CT, and HCPCS and CPT codes. From the individual, it's probably observations related to the output of a survey or a fixed set of questions. That makes sense?
Yes. So then, Bob, a final question to you. You probably won't be the last one from me, but anyway, so do you have interaction diagrams in your IG that define that kind of interaction, that closed loop interactions?
We do with the service provider, absolutely. They're there,
Okay.
including working through an intermediary like a coordination platform. We don't have it for the individual, although it'll be a derivation on what's there. And we plan on expanding on that with the individual. Plus, we're creating a reference implementation for a web app or a smartphone. And we plan on making that part of the next version of the guide, which at this point, our intent is to go to ballot with that in January.
Okay, thank you.
All right, that was really helpful discussion, and we'll definitely be, so as I mentioned, we're still in progress with figuring out the value sets and FHIR approaches to underlie these data elements. These are sort of the idealized data elements at this point, and some of them may or may not have existing standards to support them, but we will certainly be looking to the Gravity Project's work for closed loop referral as well as 360X. The next section was provision of. We actually subdivided this this intervention set into several subsets just because there was a lot here. So the first one is the provision of meds. So again, we have numerous medication classes relevant to our use case conditions. Many of these have existing value sets, and thankfully so. We won't need to be creating new ones, I think, for most of them, but we are still in the process of reviewing those. One thing that is a little unique that we also added aside from the medications themselves is sort of this acknowledgement of pill burden, which sort of goes along with this space, sort of the number of medications and pills that the individual is expected to take as a result of medication interventions. Then the next one is immunizations. So that's a relatively smaller category, but acknowledging those here. And then surgery. So in addition to numerous specific surgery types, we also have sort of an any surgery value set, which is intended to just capture general receipt of surgery, which the group felt was important to track overall. And then also non-surgical services, non-pharmacological pain treatments, PCI. So I guess I won't read through all of these, but these kind of sort of cover relevant services across our use case conditions and sort of cross-cutting themes, including some social services, social support services. Again, we're following Gravity on those. Provision of devices, again, specific to our use case conditions. And then counseling. And I'll just pause briefly on each slide in case anything strikes somebody's or catches somebody's eye. And then education. Again, these span clinical education needs as well as social support education needs. And then assessments. Assessments was an interesting category. You know, there was some discussion among our technical expert panels of the degree to which assessments were useful in the care planning context, you know, versus having the actual results of the assessments, which we included in the health status and evaluation section. And so we did ultimately decide to include them because of, you know, ability to do some population health tracking, sort of built from the data that comes from the eCare plan. So were these, you know, often these are sort of, you know, did the person receive their diabetic foot exam? Did the person, you know, receive these different services? Maybe a question that would need to be asked in addition to what the specific result of the assessment was. So ultimately we did decide to keep them. And then evaluation of eligibility for, many of these are social support services, but we also have transplant eligibility and surgery eligibility evaluations. And then assistance with, so these are non-clinical aid tasks. Again, many of them are application assistance related to social support programs, but also telehealth visit support. And then coordination of, which is a smaller category. And then finally, self-management activities, which was the section that we added on top of the sort of the gravity identified sections. So that is all of our intervention elements. And again, just want to return to our objective for today, which was to get feedback on these data elements. And so I just want to highlight the opportunities for feedback. So of course, any immediate feedback on what you've seen today, we can have those discussions now, or feel free to chat or email me if you have questions that you don't want to raise on a call today. I also have a link here at our data element spreadsheet, which itemizes all of the individual data elements that we just showed you, as well as their definition. So if there's anything that you're not sure what it means from the name, you can check out this spreadsheet, and the element definition will be there as well. And then we are in the process, as I said, of identifying the value sets and building those. And then we'll be building those out. And we hope to complete that by late September. And once we do, we will add them to our spreadsheet that tracks the actual value sets, which I think you've seen before for our other care plan sections. And I think that is all I have. So, so I guess I will pause for any comments, any questions, and I'm happy to navigate back to other slides if anybody wants to take another look at anything. And I'll also call out Joe just put in the chat, Evelyn in my presentation at HIMSS last week, if anybody is curious to see that.
Thank you, Jenna. Sorry, go ahead.
No, thanks, Jenna. That was great. I think the only thing that I'm a little curious about is the difference between the assessment and evaluation. The nuance, yeah. So that's the only one part that I like. Yeah, so separated them out, but.
Well, and I can't take credit for that. That was all work done by the Gravity Project that we just sort of used in order to try to make our projects better aligned. So the difference, I think, is assessments are actually looking at, you know, trying to identify clinical observations and interpretations of those observations. So these might be like, I actually gave this person a questionnaire to see if they have depression, you know, if they're, you know, have depression risk factors, or, you know, I palpated their abdomen. So I actually went through that procedure. Whereas the evaluation, and I think maybe it's a little, because the evaluation is highlighted, but it's actually evaluation of eligibility. So this would be, you know, do I meet the financial cutoffs to get, you know, SNAP benefits, or, do I meet the clinical requirements to receive a transplant? Things like that.
Okay, so this is tied more to things like, coverage and things like, okay. All right.
Yeah.
So actually, this caught my eye and ear as well, both of these. So evaluation, first of all, you're on that. I mean, as I think Jenna's aware, I'm doing some work on preventive care, and within preventive care is eligibility. So one area we're working on specifically right now is lung cancer screening, and there's a recent decision memo from CMS on reimbursement and the need to have shared decision making. So there is eligibility between 50 and 80, a current smoker or a former smoker within the last 50. There are very specific criteria to evaluate whether they're eligible for specifically CMS reimbursement for that lung cancer screening and then associated shared decision-making encounters to assist in deciding whether or not the patient wants to have that. So that's an example of, I'm looking at eligibility as being an interesting area. That's one specific example, but across the board in the preventive care guidelines, there are many other eligibility which often are tied to CMS reimbursement associated with that.
Yeah, and I think it comes back to, in the care planning context, if somebody's not able to pay for these services themselves, and they're also not eligible to receive, assistance or support with getting them, that may be a barrier to them actually completing that intervention. And so
I'm also indicating that the eligibility is, or the evaluation for the eligibility is, or screening is due for the patient. So, this actually ties something I've been thinking about, right now, is having some back-end decision support processes that evaluate across a cohort of patients to say that each patient is eligible for these specific preventive care screenings, and add that to the patient's care plan from the point of view of engaging the patient, whether or not they want to choose to have that screening. So it actually is, that's the work with Alex Christ, is actively engaging the patient, making the decision on whether or not they want to choose that.
Right.
Breast cancer screening is another, between 40 and 49. It's recommended, but part of it is putting that on the patient's plan to engage in that conversation with, with some educational content associated with it, as well as ultimately then a shared decision-making session, which may or may not result in a related procedure. So there's a set of care planning activities that actively engage the patient in awareness that they need education, that screening may be, an option for them. And so I'm trying to put that in the context of a care plan resource to sort of track that and to add it to the care plan resource for the patient when it's appropriate, to bring it to the attention of both the provider team and to the patient.
Thanks, Dave. That's really interesting. Go ahead, Stephen.
So under the patient care plan conference page, we have another page that discuss about the goal assessment and also evaluation, where we make some distinctions between how assessment and evaluations constructs are being used. So it might be useful for you guys to take a look and let us know what you think about it, and whether the information is useful or you have new content that would help us enrich what we have already put there.
Good, yeah, thanks, Steve. And I've looked at some of the slides that you sent out recently, and also thinking about where and when goal is appropriate in a wide range, really, of preventive care planning. It's obviously a general goal to be up to date on all of your preventive care screenings, which could number in the dozens.
This is interesting. So, Stephen, I've clicked on the link you put in the chat, and I'm just looking at the, the way assessment and evaluation are sort of distinguished. And I think it makes sense on the one hand, but I guess to the degree, I guess I've always thought of care planning as a cyclical process, right? And so I'm curious as to your take on, at what point, since it's not always a linear process, right? I think assessment being formative and evaluation being sort of summative, as you sort of put on this link that you shared. At some point, you have to kind of start the process over again, and then is at that point your evaluation also an assessment for sort of the next phase of what you're going to do?
Yeah, in a circle diagram that I also included in the slide deck that Dave mentioned, I try to depict the concept that the care process and also the patient journey process is not necessarily a linear process. It's more of a recurrent process where your starting point is that you need to find out what the problems or health concerns or issues that the patient might have in order for you to start the care planning process and also instantiation of a care plan. And from there on, you would go through a recurrent process of continuous CQI, which will require your evaluation of various things that are happening with the patient and their implications or impact on the patient's health status or progress. And so therefore, it sort of arising from that, sort of the concept of evaluation as distinct from the initial assessment for which would allow you to arrive at a set of health concerns or issues or problems. And the evaluation processes require the comparison of sort of like what the current status of the patients is versus the interventions that has been performed, and also the goals that has been set for the patient or in conjunction with the patient, and where we are at with regarding to the goal progress. And so therefore the concept of evaluation allow us to arrive at some kind of judgment, if you may, for the lack of a better choice of word, as to whether or not the goal that we have set, where the patient's health status is, and whether or not the goal that has been set out or the milestones that have been set out has been reached. So hence the distinction. So it might, I mean, this might sort of attract a considerable degree of dissent, and I'm more than happy to hear as to sort of what colleagues' thoughts are and how we can refine those concepts. And for a while, we settle on this is how the two concepts are being used. And if for the MCC project, you come up with a different way of looking at those two concepts, we're more than happy to hear them.
Well, it's interesting because I think it kind of depends on the context, and I see what you're saying, and I actually scrolled further down the page, and I think I see your circular diagram where you sort of have evaluation as sort of reassessment, and I liked the construct that you added of in order to evaluate, you have to kind of see where you started, what you did, and then where you got to, right? Yeah. But I think from a value set perspective, the same things that you do, right? Like the screener that you use or the physical exam that you give might be the same whether you're doing an assessment or an evaluation, right? You're going to take the results of that and say, okay, this is where the patient is. But the added part of that evaluation is then sort of the comparison of to where they were before, and sort of the thought about, did whatever intervention this patient went through, did it work? Was it the right intervention? Was it useful? Or where did it break down if they didn't show an improvement? So right. Kind of it's a little bit broader. No, so I mean, I think that's a useful paradigm and I like it. But at the same time, in terms of data elements and value sets, I think they would be almost in some ways the same, or at least I'm struggling to think of I don't know that there. It's interesting because there is this added work in some ways that maybe isn't being really tracked, I think, with our given codes, right? Because that process of actually comparing isn't necessarily codified. That's interesting. I don't know.
Yeah,
I'm sort of rambling.
No. I mean, thinking aloud is always a very useful process. I think what probably needs to be done is to look at how those two concepts can be codified, and if they end up with, for those two concepts, if they end up with similar sort of value set, and yet my expectation is the evaluation component probably would have some extra kind of value sets to be able to allow sort of the concept of evaluations to be more fully and semantically clearly expressed. So that's an exercise that we haven't done. We have done the conceptual analysis, but when it comes to value set, we are not there yet, and that exercise would need to be done as the Care Plan DEM 2.0 work progresses. At the moment, we have done a lot of work in terms of those concept analysis and come up with a logical way of describing them.
Yeah.
I also just want to comment briefly on the assessment as well. And that's also doing some thought in that area where, from the care planning perspective and looking at evidence-based guidelines that recommend assessments, part of what I'm considering here is the frequency and the appropriate instrument depends upon specific guidelines and the patient's situation. So whether it's chronic pain, there's many different pain assessment instruments, the frequency that one or perhaps multiple alternative instruments are used depending upon that patient's specific situation. So, I've been considering like a service request for an assessment of pain or mental health or anxiety, which recommends the specific appropriate instrument and frequency of use of that instrument. So when I think about assessments, I'm often thinking about in that context, whereas Jenna, like where you do kind of differentiate with evaluation, where I'm evaluating then progress or lack of progress, or perhaps indicators that a new counseling intervention may be needed as a result of an assessment instrument. But when I think assessment, I'm also trying to figure out how to create appropriate assessments and add them to a patient's care plan based upon guidelines.
Dave, my response to your analysis is yes and no. From a formal perspectives, the concept of clinical assessment is in itself actually a process, and the process itself does use a certain amount or types of tools, but they do not necessarily need to be tool-based, and hence the concept of initially when we were trying to create a file resource, I proposed the concept of clinical assessment because that's a very formal concept that's very well known both to doctors, nurses, and any of the clinical sort of healthcare professionals, but the concept got derailed because of the potential confusion with assessment tools. So I keep on arguing that that is not the rationale for not use the concept of clinical assessment, because that is a formal process where if we know that the clinical assessment itself consists of past and present health histories, a physical examination, some kind of diagnostic test, and the physical examination and history taking themselves might lend themselves to the use of a set of assessment tools, like the psychometric assessment tools, like the EPGAR scores, like the Glasgow Coma scale, that kind of thing. So it doesn't mean that the concept of clinical assessment or assessment is the equivalent or synonymous with the tools, but it does sort of is a process in itself that consists of multiple components, and I try to sort of distinguish the concept of assessment from the evaluation, where the evaluation itself does sort of go into fit into the CQI process, where assessment is part and parcel of the evaluation activity.
Well, thank you very much. I appreciate that. To really more clearly, obviously is using assessment instrument in a much narrower context. But yeah, thanks. It's good. It's helpful.
Right. Yeah. So if I may sort of venture to make a bold statement, I would argue that the assessment itself is part and parcel of the evaluation process. Anyway, that is a very interesting discussion. I really appreciate that. Any other questions from colleagues? If not, then in the non-surgical interventions, Jenna, that you presented earlier, I seem not to notice nursing components in there. So I might have overlooked in the haste, but if there isn't a nursing non-surgical services included in there, where would you represent nursing activities or therapies?
That's a good question. I guess we, I don't know that we've necessarily parsed it out by who, obviously we have the sort of attribute of who's providing the care. But, I guess I think if we wanted to include data elements, and there may be data elements lacking that we need to include, but I guess what specific activities do you mean? Because I don't think we necessarily would parse it by the role of the person providing it, but by the actual, did they receive the service or not?
Yeah, the reason why I ask is that you have speech therapy, you have physical therapy, you have occupational therapy that are discipline specific. Nurses sort of perform a whole lot of interventional activities. I'm just asking whether or not that needs to be considered. And that's, yes?
Yeah, this is Emma. I think, and Jenna, tell me if I'm incorrect. I think that the thing we need to take into consideration here is there's a payment undertone to some of these data elements, right? So you typically do not pay, like have a bill, a CPT code for nursing services. You have, you can bill for speech therapy, and you can bill for physical therapy. You can bill for the things that nurses do, you can bill for wound care, and you can bill for the, education pieces that nurses provide, but they may not necessarily bill for nursing care, at like that.
Yeah, and I think that's part of it, Emma, because I think, we have sort of tweaked the data elements as we've started to look at available codes to support them. Yeah. And originally we had thought about parsing out physical therapy in more detail, but looking at the codes available, at least thus far, and we may go back to parsing it out in more detail. A lot of the codes available currently to support that are pretty generic and speak to sort of a broad set of services that you receive you know, so I acknowledge, because that is sort of, in some ways, it is like the role dependent, right? Physical therapy is provided by the physical therapist, but it's sort of a set of,
because any, you know, nurses could do the exercises, and the billing would be for the therapy. Not, you know what I mean? In some situations.
right. And education is often provided by nurses, and that's, you know, and counseling.
And that's why nurses joke that we're included in the room. You know, those services. Yeah, you know, it's because our services is not a billable line item. It's the things that we do that is billable.
But at the same time, Emma, we are interested, I think, too, in thinking about gaps in coding. And so I don't know, you know, what the better, you know, I would welcome input on this from this group, and not, you know, what the better approach is. Like, do we need to better parse out physical therapy services, so we're actually talking about the specific individual things you do in physical therapy, so that we have the codes to say, you know, this person,
and I think
versus
if you were to actually look at like a physical therapy EOB, or, you know what I'm saying, you would see the different modalities and stuff that gets filled out. I would be scared to try to even, you know, say what nursing care should be. I mean, you know, should be built. I don't think most times nurses do not even want to go near how much it will cost for the care that we provide. I don't know. I don't want to get into that conversation with
Emma. I thought that I am putting my sort of
I know, right? I was like,
nurses hat
Steven.
on.
You know, I said, I'll go, Steven. I'm not touching that. But anyway,
Okay.
but I may be wrong though, you know. But I think, yeah, I may be wrong. But I know from, you know, years of working home care and stuff like that.
I was thinking that Emma should be proud of me and say that, Stephen, being a physician, hasn't forgotten his nursing roots.
I got a little excited. I'm like, oh, somebody's thinking about us. But great, thank you. But I think that's, you know, when I look at this, I see the payment aspect of it underlying that.
Yeah, I mean, I do think that comes into play with the codes we have available. But Emma and Stephen, if you guys think of, you know, specific things that we can or should add that are missing here, you know, particularly with regard to nursing services. We did have a lot of nurses on our chat, so I hope, you know, I hope that we've reflected the nursing discipline at least somewhat well. But I think, yeah, nurses do provide so many services, and, you know, a lot of them are I don't know what, I can't find the right word, but right there are things that are so just, you know, quality of life intertwined, and like, I don't even, I'm struggling to kind of, like, there's so many things that I think nurses do that just, you're right, aren't sort of well recognized, and are maybe very specific to the individual needs of a given patient to make, you know, anyway, I'm rambling.
I definitely agree, because you can do one type of therapy for one patient and it might be, you know, straightforward, nothing to it, you know, not a lot of time. And you can do the same therapy to a second patient, but it might be a lot more complicated because of the, you know, patients are different.
Mm-hmm.
You know, you can go into one home, teach one family IV therapy, how to administer this, and you're out of there. You go into another home, you might have to go there like 6-7 times trying to teach the same thing, you know, because people are all different. So, and I think it's kind of hard to put value or, you know, billing around those kinds of services like that.
Yeah.
It's all, you know, it's all qualitative.
Can you put it down in, can you isolate it into hours spent or time spent, Emma?
You can try. You get right, but you know, you may be in one home and you may not even be teaching how to start the IV, but you may be more talking to somebody and trying to calm them down, you know, and you know, that kind of thing.
Reassure.
Yeah, reassuring them and things like that.
Yeah. And I mean, I think to some degree, we hope to capture those things through education and counseling
Yeah, yeah.
that would be, acknowledged as provided by the nurse in the care plan. I think if that were the case.
Yeah, so that's what, yeah. And that's why we were fighting so hard for fire to give us an education resource, but we didn't get it.
Well, not yet.
We got lumped in with procedure.
Right. Jenna, if we are done with this discussion, so can you backtrack your slide to the beginning of the metadata for the intervention? So I have a question for Dave with regarding to that. There are, from what I've seen here, there are a lot of data elements in here that are that the fire resource hasn't catered for. Dave, in your work, do you think that you need to create a whole lot of profiles and extensions to meet those extra data elements that you might want to capture for the project?
That's a really loaded question, Stephen. Thank you for that or not. I guess, in response that I know it's kind of a non-answer, but, it's a case by case. I'll just cite some of our work within VA. One of our concerns is a proliferation of extensions that are not managed, maybe duplicative on a project by project basis. And it's difficult to take all of those requirements into a formal standards process, but we're doing our best to harmonize the requests. So the work done here is an excellent general view of what might ultimately be the gaps. But where and how these become extensions on the base fire resources, that it can be driven by project demands more than trying to address them all up front. I know, Emma, what you've been involved in this, as probably even more so than I in IHE and other environments.
Yeah, I can tell you, just looking at that list, out-of-pocket costs, if anything that has cost related is probably going to be an extension.
Yeah, and this, oh, sorry, go ahead, Emma.
Now I was going to say the only other suggestion I have for the value set is for us to try not to make that value set so too tight, to make it extensible or preferred bindings, because we know there are things that are going to be needed, to be added to it or tweaked or something.
But there's some elements on here that are so important and come up in other recent conversations, like past failure or reason for failure. That just came up again. I think it's arguably, should be a core concept in understanding what was attempted in the past, whether it's a medication or a procedure or education as an intervention, and learn from that and have it available.
But wouldn't that tie into the outcome though?
It does. It's partly about the outcome, but partly about what was attempted.
Yeah.
Right? We may, and especially in the clinical records, may not have the formal outcome that a medication did not succeed in lowering a blood pressure. But yet we very much want to have a record of the fact that a medication or some, it's like in hypertension, the first order is to look at lifestyle, and that a number of different attempts were made to lower blood pressure through several very specific lifestyle interventions, including referral to community services, but the blood pressure did not drop below recommendations. How do you keep a record of what was tried that didn't successfully get to our goal?
Yeah, so part of the reason for me to ask you that question, which yes, I agree to a certain degree that is a bit overloaded, is that I see your point of, and it's my philosophy as well, to have as few profiles and extensions as possible, And some of the elements that I've looked at there strike me as you have echoed echo my unspoken sentiment until now, that appear to me to be quite critical. And in the past, I myself and a lot of patient care clinical folks have been fighting the battle of getting a lot of those clinically meaningful and important concepts to be included in the FHIR structure definitions. And we've got a lot of pushbacks from Deloitte and co. In arguing that FHIR is not about promoting best clinical practice, and it's about sort of a standard for implementers. So, and I'm coming back to my passion, hobby horse of wanting the FHIR resources to be clinically not only meaningful, but clinically fit for purpose. And the reason of asking you whether the profile or extension is the pathway that you're taking is I'm hoping that there is some kind of alliances from you guys who are actively implementing it, in acknowledging that the concepts of extensions and profiles are fraught with problems, and a lot of those elements that are clinically meaningful and important shouldn't be pushed into extensions and profile, and should be in the base resource.
So I mean, one final thought to this conversation too is extensions or profiles. I'm finding it helpful to think about collections of reusable extensions, whether or not they are collected together into a profile. So for example, we have some of this in FHIR already of a number of standard extensions. They aren't necessarily part of a specific sort of clinical domain specific profile, but yet we can agree upon the identifier for that extension and precisely what value sets are used for codes in the extension, for example, and have this library of extensions available. I think that'd be very helpful, just as a way to define the extensions of which resource are applicable to without necessarily putting them into an IG and a profile.
Emma, was it you who were trying to say something?
No, I was listening. No, but yeah, there are a list of FHIR standard extensions, and I think the more we can recognize, the less implementers will create their own.
And do it in a consistent way. And I'll say just echo from a number of my colleagues with some GA projects, we have a great concern about proliferation of extensions created by each individual project. So maybe one way to approach this within the MCC IG is as a collection of standard extensions defined within the IG, but not necessarily assign them to a specific profile.
Right. So I thank you so much. It's been a very useful conversation, and my apology again for asking too many questions. Hopefully colleagues will bear with me. Any other questions?
I really like, I think the idea of past failure though, I think, how do you know that it has failed is probably because you did an assessment. Yeah. I think just having a static list or a static attribute on the intervention without pulling in the other pieces of the process, you know, like, did you assess, then you found a failure, or do you just stamp an intervention with an attribute of failure? You know what I'm saying? So I think we really need to kind of flush that out to see how it fits into the whole circular assess and reassess process that we go through with the care planning piece.
Yeah, Emma, that that I think we need to relook at the relationship between the structural component of the care plan and also the behavioral components of the care plan, and how the two of them can
and work together. Exactly.
Yeah, can work together. Yes.
Because if we don't do that, we will start to get disconnect, where you may
Yes.
have an attribute on an intervention, you know, Boolean, failed, did not fail. But when you look at that, when you go to the assessment process, you see that it did fail. You know what I'm saying? So we need to do that.
Right. Okay, so we have gone past the top of the hours a little bit. So I think it's a unless we have other questions, this would be a good point to say thank you to Jenna and Dave and Joe and your team in constantly feeding us with these rich questions and stimulation for thoughts, and heads to you guys for the wonderful work that you have done.
Really, I want to really commend you guys for doing this, and it gets me excited because when we talk to Lloyd about activities in care plan and intervention in care plan, everything was in the future, you know, and I'm like, what about the things that have been done? What about the things that have been done? You know, this is not a, you know, I think the word plan, because we get a lot of questions about future looking things, and nobody talks about what the things that were done or the things that are in the process of being done.
Yeah, and hence
I'm really excited about this.
Yeah, and hence the concept of sort of patient status, progress, and also outcome. Would point to the direction that is care plan itself is not totally future looking. But yeah.
Well,
anyway,
thank you guys for all your input and help. we certainly couldn't do this without you guys, and you will definitely take back, you know, all the input and keep you guys updated as this moves forward. And I agree. I think your point is good, that we have to be careful about, you know, past failure, like labeling things and making sure, you know, that's thoughtful about how we do that. So.
Right. Thank you. So Jenna, your slide will be available to us.
Yes, I'll circulate those.
Yeah. So if you either give it to me and Joe, and then we'll make sure that it's uploaded onto the conference page. That would be great.
I will do that.
Okay. Thank you. All right. Thanks everyone for this very interesting and stimulating discussions. So we'll see you guys again next week with a guest speaker, right?
2 weeks from today.
Oh, sorry, 2 weeks from today. Okay. Yep.
2
All
weeks.
right, thank you. All right. Yep.
All right. Thanks.
All right.
Bye-bye.
Thank
you.
All right. Bye.
Thanks.